Welcome to our video on mitral valve diseases. Let's begin. In this lecture, we will cover the mitral valve diseases, including mitral valve prolapse, regurgitation, and stenosis. Let's start with mitral valve prolapse. For each of the previously mentioned conditions, we will be reviewing the following components, including the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Here is a table summarizing some key points of each of the conditions we will cover. Notice that almost all the valvular heart conditions can present very similarly in regards to their clinical features. Knowing this, we must focus in on key differentiating features of the murmurs each condition produces, and other distinguishing findings to differentiate between all of these valvular disorders. Mitral valve prolapse is defined as a structural defect in mitral valve which leads to the bulging of the valvular leaflets into the left atrium during systole. Specifically, the current definition includes any mitral leaflets that billow into left atrium greater than 2 millimeters above the annular plane. This condition is mostly idiopathic. Of note, mitral valve prolapse is the most common cause of mitral regurgitation. Here we see an image of mitral valve prolapse. As you can see, the arrows represent the flow of blood during systole as the heart contracts. The mitral valve then is flailing or billowing into the left atrium during systole. Keep in mind, this can occur due to damage to any part of the valvular apparatus, including the chordae tendineae or papillary muscles. Let's talk a bit about the pathophysiology of mitral valve prolapse. The most common cause of mitral valve prolapse, as previously mentioned, is myxomatous degeneration. This is the process in which deposition of glycosaminoglycans lead to degeneration of structural integrity of the valve. This will lead to long, floppy, and unstable mitral leaflets with excessive valvular tissue. The mitral annulus then becomes dilated and chordae tendineae may become elongated and possibly rupture, leading to flailing of mitral leaflets into the left atrium during systole. In severe cases, this can even lead to mitral regurgitation. Other valvular abnormalities are a risk factor for mitral valve prolapse, as they are often associated with this condition, primarily tricuspid and aortic valve defects. Risk factors also include thoracic skeletal abnormalities, von Willebrand disease, a family history of mitral valve prolapse, and connective tissue disorders such as Marfan and Ehlers-Danlos syndromes. Damage to the valvular apparatus can also come secondary to prior infective endocarditis or rheumatic disease, therefore increasing the risk for mitral valve prolapse to develop. Myocardial infarctions can also cause similar damage to cardiac tissues. Mitral valve prolapse is typically asymptomatic, but can cause atypical chest pains and palpitations. The murmur produced by mitral valve prolapse is described as a mid-systolic click followed by mid to late systolic murmur at the mitral area, typically found at the fifth intercostal space at the mid-clavicular line. What effect would standing maneuver have on murmur heard on mitral valve prolapse? Here we have a depiction of the classic murmur heard in mitral valve prolapse, a mid-systolic click followed by systolic murmur. Standing reduces venous return and therefore slightly less blood will fill the ventricle. When this happens, the mitral valves take slightly less time to flail into left atrium due to the fact that the smaller ventricular volume leads to less stretch on the mitral annulus and a more easily compliant mitral valve leaflet. Imagine the valve as a rubber band stretched as far as possible between 2 points. If those 2 points are brought closer together, the rubber band more easily flops around. Therefore, standing would make the classic mid-systolic click, heard before the murmur in mitral valve prolapse, occur slightly earlier in systole, and the murmur would also lengthen. Diagnosis is once again confirmed by the echocardiogram, which demonstrates flailing of faulty mitral valve leaflets above the mitral annulus. This is further defined on imaging by mitral leaflets that flail more than 2 millimeters above the mitral annulus during systole. Here we can see what a severe mitral valve prolapse may look like during systole on echocardiogram. The hyperechoic structures here represent the mitral leaflets flailing open during systole. In a structurally normal heart, you would anticipate these 2 leaflets to be touching and remain closed, appearing a solid white line during systole on echocardiogram. Mitral valve prolapse is largely a benign condition, and those without symptoms may be reassured as such. In individuals who experience symptoms, beta blockers may relieve chest pain and palpitations. Which extra heart sound may present in worsening mitral valve prolapse? An S3 heart sound can develop as a result of left ventricular volume overload if mitral valve prolapse progresses to mitral regurgitation. S3 is typically heard immediately after S2 during early diastole and may be described as a low-frequency sound. It typically reflects an increase in the atrial pressures leading to increased flow rates of blood filling the left ventricle. Think of it as a large amount of blood entering the left ventricle rapidly striking against a very compliant left ventricle. Let's move on to mitral stenosis, our next condition. Mitral stenosis is due to the thickening of mitral valve leaflets leading to a mechanical obstruction of blood flow from the left atrium into the left ventricle. This thickening is almost always due to rheumatic heart disease, but can also be due to age-related calcification or radiation-induced tissue changes. The pathophysiologic process of mitral valve stenosis begins when stenotic valve leads to obstruction of blood flow into the left ventricle during diastole. This will in turn decrease the left ventricle end diastolic volume and thereby decreasing stroke volume, eventually leading to decrease in cardiac output and forward heart failure. A severely stenotic valve will over time also increase left atrial pressures, leading to a backup of blood flow into the lungs and increasing pulmonary capillary pressure. This can cause cardiogenic pulmonary edema and lead to pulmonary hypertension. Here you can see a depiction of a stenotic mitral valve. As the heart relaxes and the left ventricle fills with blood, the stenotic mitral valve will partially obstruct the flow and thereby the end diastolic volume will be decreased, indicated here by the red area showing a partially filled left ventricle. This narrowed mitral valve will also increase pressures in the left atrium, leading to the aforementioned pulmonary edema and pulmonary hypertension. Risk factors for mitral valve stenosis are a history of rheumatic disease of congenital defects in mitral valve, which are very rare. Why may a patient with long-standing mitral valve stenosis have trouble swallowing? Chronic long-standing mitral valve stenosis can lead to left atrial dilation so much that it can cause something known as cardiovascular dysphagia. This occurs when the enlarged left atrium is displaced posteriorly, causing external compression of the esophagus. On rare occasions, this can also cause compression of the left recurrent laryngeal nerve and lead to chronic cough or voice hoarseness. The presentation of mitral stenosis is similar to that of other valvular pathologies, which includes a typically asymptomatic course for many years, followed by potential exertional dyspnea, orthopnea, palpitations, or angina. The physical exam findings may be used to narrow down your diagnosis. This includes the murmur heard in mitral valve stenosis, which is described as a diastolic opening snap sound, followed by low-pitched murmur best heard over cardiac apex. A chest X-ray may show left atrial enlargement in chronic cases. Echocardiogram is used to confirm diagnosis. Echocardiogram would demonstrate narrowing of the mitral orifice. In a setting of rheumatic heart disease, the echo would show commissural fusion resulting in a pattern of diastolic doming with the leaflet tips pointing toward each other in mid-diastole. If mitral valve stenosis is discovered and the patient is asymptomatic, then no therapy is warranted. If patients are symptomatic, pulmonary congestion can be treated with diuretics. Heart rate can be controlled with beta blockers. If an atrial fibrillation is present or patients have history of prior embolic event, then long-term oral anticoagulation is recommended. Valve replacement is indicated in severe disease. Why is atrial fibrillation associated with mitral stenosis? What is this often a warning sign of? Atrial fibrillation is associated with mitral stenosis due to the fact that left atrial dilation is very common. This morphological change can disrupt the electrical conduction through the atria. Atrial fibrillation in the setting of mitral stenosis often precipitates acute decompensation because not enough pressure can be generated to overcome the elevated left atrial pressures and provide adequate blood flow across the stenotic valve. Moving right along to our next valvular condition, which is mitral regurgitation. Mitral regurgitation is defined as inadequate closure of the mitral valve, leading to regurgitation of blood flow across the valvular annulus during systole. Now to review the pathophysiologic process of mitral regurgitation. This process will seem similar to that of aortic regurgitation, as any part of the mitral apparatus, including chordae tendineae or papillary muscles, are damaged, leading to improper closure of the mitral valve and an increased end diastolic volume load on the left ventricle. The heart will compensate to this increased load and left ventricle pressures, just as in aortic regurgitation, by increasing the heart rate. In chronic mitral regurgitation, the left ventricle will respond to accommodate the excess volume load by dilation and hypertrophy to balance wall stress, just as we previously illustrated with the law of Laplace on the aortic regurgitation slides. During this time, patients typically remain asymptomatic. However, the natural history of this pathologic process will eventually lead to decompensation of our compensatory mechanisms. Although the transition to a decompensated state is poorly understood, it is associated with continued dilation of the left ventricle, increased systolic wall stress, and a decline in ejection fraction. At this point, patients may experience symptoms as they progress to heart failure, which is often accompanied by left atrial enlargement, atrial arrhythmias, and pulmonary hypertension as more blood flows back into atrium during systole. This image displays the direction of blood flow during systole in the setting of mitral valve insufficiency. As you can see, blood will flow both in the appropriate direction along the aortic outflow tract and inappropriately back across the inadequately closed mitral valve. Mitral regurgitation is most commonly caused by mitral valve prolapse, which leads to regurgitant blood flow across an incompetent mitral valve. It is important to note, acute and chronic typically have different causes. Acute mitral regurgitation is caused by infective endocarditis, papillary muscle or chordae tendineae rupture, likely in the setting of previously damaged cardiac tissue, while the chronic condition is caused by prior mitral valve prolapse, rheumatic disease, connective tissue disorders, and cardiomyopathy, causing dilation of the annulus. Other conditions that can cause chronic mitral valve regurgitation are coronary artery disease leading to regional wall motion abnormalities, which distort the valve apparatus, and valvular calcification, which is typically age-related. Which neurocutaneous disorder has been associated with mitral regurgitation? Tuberous sclerosis is associated with mitral regurgitation, as the individuals with this condition can often have cardiac rhabdomyomas around the mitral annulus that lead to regurgitation. Key symptomatic features include dyspnea, orthopnea, paroxysmal nocturnal dyspnea, palpitations. Physical exam may reveal a decreased or absent S1 heart sound, S3 heart sound, or a holosystolic murmur best heard at cardiac apex, with possible radiation to the axilla. Diagnosis is confirmed with an echocardiogram, which displays a backflow of blood across the valve during systole on Doppler and/or flail leaflets of the valve and possible annular dilation. Surgical correction of mitral regurgitation is indicated even in asymptomatic patients if left ventricular ejection fraction is between 30 to 60% and/or left ventricular end systolic diameter is over 40 millimeters. In symptomatic patients, you can reduce afterload medically with vasodilators, and prophylactic anticoagulation is indicated if atrial fibrillation is present. Surgical repair or replacement in symptomatic patients is indicated in chronic cases if left ventricular ejection fraction is greater than 30%, or if left ventricular ejection fraction is less than 30% and the patient has a high likelihood of successful repair. Why do arterial vasodilators improve symptoms of mitral regurgitation? Left ventricular afterload is a major determinant of forward to regurgitant flow ratio in patients with mitral regurgitation. Therefore, reducing left ventricular afterload with arterial dilation can cause an increased forward blood flow while reducing regurgitant flow and thereby improving symptoms. So let's read a question. A 43-year-old male presents to the emergency room after an episode of palpitations on his walk this morning, which resolved after about 10 minutes. He has had recurrent shortness of breath upon exertion over the past 3 months, but never experienced palpitations. He has mild trouble breathing while going to bed at night. He denies cough or chest pain. The patient states he's never smoked and has a remote history of rheumatic fever as a child. He is otherwise healthy. On physical exam, his temperature is 37.3 degrees Celsius. Respiratory rate is 15, heart rate is 80, and blood pressure is 129/79. His lungs are clear to auscultation bilaterally, and a systolic cardiac murmur is heard at the apex of the heart, which decreases with Valsalva maneuver. He has mild lower extremity swelling. CBC, troponin, EKG, and chest X-ray are all unremarkable. What is the most likely diagnosis? A. Aortic regurgitation. B. Chronic mitral regurgitation. C. Pulmonary embolism. D. Congestive heart failure. Or E. Ventricular septal defect. So at this point, in summary, we have a 43-year-old male with a sporadic, self-limited episode of palpitations who has experienced shortness of breath and mild orthopnea for the past 3 months. Physical exam gives us a systolic murmur heard at the apex, which decreases with Valsalva maneuver due to the decreased preload and an otherwise normal cardiac workup. What is the most likely diagnosis? B. Chronic mitral regurgitation is the correct answer. Let's explore why. Our patient's exertional dyspnea, palpitations, mild edema, orthopnea, systolic murmur heard at the cardiac apex that decreases with Valsalva and normal cardiac workup makes mitral regurgitation the most likely diagnosis. This diagnosis would need to be confirmed with an echocardiogram. It is also just as useful in preparation to go over why the other answer options are incorrect, so let's do that now. Aortic regurgitation, option A, may present with similar clinical symptoms. However, we can use history of rheumatic disease, which more likely is due to the effective mitral valve, as a hint in the right direction. Also, the physical exam is more in alignment with mitral valve regurgitation, a systolic murmur at the apex of the heart which decreases with Valsalva maneuver, is not expected in the case of aortic regurgitation. A description of classic aortic regurgitation murmur may mention a decrescendo diastolic murmur heard loudest at the right sternal border. Pulmonary embolism, option C, would likely present in a more acute manner than this patient's chronic presentation. Ventricular septal defect is less likely to fit history of rheumatic disease, and the murmur would likely be described as a holosystolic blowing murmur located at the left sternal border rather than the one we see in the question stem. Congestive heart failure, option D, could also present with orthopnea, shortness of breath, and palpitations, but a murmur would not necessarily be anticipated. A patient with symptomatic congestive heart failure may also have jugular venous distension or edema of lower extremities, which is not mentioned here. And this concludes our presentation on mitral valve diseases.